Hi, my name is Marquisha Miles. I'm the Community Health and Image and Breakthrough to Nursing Director for the Michigan Nursing Student Association. Today I'm joined with Dr. Stephen Roscos. Can you tell me a little bit about yourself?
Sure. I'm an associate professor in the Department of Family Medicine at the College of Human Medicine of Michigan State, and I've worked a lot with patients with chronic pain in the primary care setting.
Awesome. So this year our community health initiative is the opioid epidemic. So today we're going to be hosting an interview and I have a few questions for you. So how do you believe the opioid epidemic started and evolved throughout America?
Well, I'm not a historian, but I practiced through the beginning of the opioid epidemic. I started in the 90s. I think that there's always been a problem with opioids, and healthcare providers have probably always recommended some types of opioids for treatment, even back in the 1800s and longer ago. But when people started manufacturing them and pharmaceutical companies started manufacturing them and marketing them, I think they became much more readily available and inexpensive for patients to get and for people to get on the street. Physicians and other healthcare providers started prescribing it more often, and it just became more available and more common.
Okay. Now, I know people do contribute some of the overuse to pain now being considered a fifth vital sign. Other people say that it's just because physicians overprescribe, and then even like you were saying, pharmaceutical companies like OxyContin possibly underplaying the risk. What do you think about that?
Well, I think all of those things had a part to play. It's really a good thing that pain is the fifth vital sign, because if you don't ask about pain, it may go untreated, and there can be not only people suffering pain as a bad effect, an undesirable effect of someone suffering in pain, but it can lead to other problems and, poor recovery, inability to return to work, all those kind of things. So it's good that we're asking patients about pain. The problem probably is that some people don't remember that there are a lot of different ways to deal with pain besides giving medication, an injection, or a pill. And so when people too quickly prescribe opioids as a treatment, I think that has led to the problem. So I don't think asking about pain is the problem.
So can you explain how the drug monitoring system works here in Michigan, and do you feel like it's been effective so far?
I can answer the second part. I do think it has been effective, okay? I think what you're talking about is probably what's called MAPS. All the prescriptions that are filled for opioids or any controlled medication in Michigan are tracked in a central computer that then I can look up anytime. I can look up my patient's name with their birth date and find out all the prescriptions they've filled in Michigan for controlled medications in the last, I think, 12 months. So that is a very useful tool to be able to tell if a patient is truly suffering from pain and needs help, which is most patients, or if that patient is one of the few patients that is just trying to get medicine to use it for an inappropriate purpose.
Okay, so you did say something about the people that actually do suffer from chronic pain and do need help. So it's been said that some of these people actually suffer as a result of this epidemic. Is there any solution for this?
Well, it's probably true that some people who have pain and need relief are not able to get that relief because of all the controls placed on opioids. I think it's really helpful to remember there are a lot of different options to treat pain, a lot of different medications and a lot of other non-medication options for treating pain. So opioids aren't the only solution. I think one thing that the controls have helped with is helping physicians and other prescribers think about all of the options available to them. Anti-inflammatories, some medications that are used for depression or for seizures are also effective for pain. Then there are other treatments like acupuncture, physical therapy, nerve stimulators, electrical nerve stimulators. So lots of different things. Really, the list is very long of all the options available for treating pain now.
Do you believe that doctors could do a better job at screening patients with a history of substance abuse or psychiatric disorders before they prescribe opioids, for instance?
So it's hard to say generally about all doctors. There's a small group of doctors who uses this epidemic as a way to make money, and that's a very small group. And the licensing board is chasing those doctors and trying to get them to stop practicing in that way. And those are doctors that, when a patient walks in, they can basically pay a certain sum and get a certain amount of, controlled medication prescription from them. That's a very, very small portion. I think most doctors are really trying to do a good job and take care of their patients and do what's best for their patients. But I think the pressures of modern practice keep them busy, and they might not have time to do a careful evaluation of a patient and their risk. So certainly some doctors could do a better job. Some of them are good doctors who are just busy or haven't had the training to do that. But there are lots of tools available to us. There's questionnaires that are really quick and easy to use to screen for one called the Opioid Risk Tool that screens for whether somebody's at risk for abuse or diversion. And there are lots of easy tools to screen for mental illness. So, it's my practice and my colleagues here at Michigan State practice to always screen people for their risk of abusing or diverting opioids and their risk of having a mental illness, which increases their risk of abusing or diverting them before we prescribe them. Yeah, what's really important is that patients have a primary care physician or another primary care provider that can get to know them over time and get to know them as a whole person and see them over time and whether they're making progress or not, and make adjustments to their treatment plan. And for some patients, opioids aren't the answer, but usually it's best not to just stop them completely all at once, but gradually decrease them while we try some other treatments.
So some people say that physicians need to have a system where they prescribe a certain amount of opioids for a certain procedure. But what about the fact that some people do experience pain differently? How do you feel about that?
Yeah, I think that's a tough one because pain is a subjective experience. What the patient says about their pain is true. We can't measure pain in any other way. And so to say that, for example, after a hip replacement, patients should get 30 hydrocodone pills, no more, no less, just makes medicine way simpler than it really is. I think that doctors and other people who prescribe need to have the freedom to prescribe what's going to benefit the patient the most. I think that more education for doctors would probably be helpful, because it's true that some patients get way more than they need after a procedure. So, prescribing a small amount and seeing how that goes, and then prescribing more if it's needed, is a better approach.
So the process of recovery can't happen just in the emergency room. So what role do family, friends, and the patient themselves play in the recovery process?
Yeah, there's a lot more to recovery from addiction than any physician or emergency room can take care of. Certainly medicine can help. There are medicines that help people with addictions to opioids recover, but usually that's just one part of the program. So clearly they need to be part of a supportive group that gives them encouragement and accountability so that they can move forward with their life, do things that are productive, find other ways to deal with their problems rather than using the drugs that they've been using. It's definitely not a problem that medicine can solve by itself. Patients who are addicted to opioids are welcome at places like Narcotics Anonymous and things like that. And then there are lots of intensive outpatient programs as well through like psychiatric hospitals or outpatient community mental health clinics for patients with addictions. And really, an opioid addiction is not categorically different from other drug addictions that patients might have and need help with.
Okay. If you have any questions, you can email me at mnsa.communityhealth@gmail.com.